Okay. Morning, everybody. Again, it's now 6 minutes past 12. And as I said, if we can just have a look at the app link. If you can just have the next slide, please, Edouard. There's the app link that you can download on your phones. It will be available afterwards as well that we can scan. As soon as you get to this, you'll see the next screen. Edouard, please. This is how it will look if you download it, so that it can help you to see what is happening. And then on the next screen, next slide, please, Edouard. You'll see in the middle button, it shows you the QR code, and that is the button that you'll have to press as soon as we display the QR code. It will scan and it will tell you in the session, and at the end will give you a different code that will allow you to scan it again, and then you'll have your attestation for that. Okay. So the next session will be the scan, the code that you can scan. We'll display this again just after Africa CDC does the update, and then you can scan it again. Thank you, Edouard. Over.
Hi, Mohammed, over to you.
Hello, good morning, everyone. Good afternoon, good evening. Can everybody see my screen? Can you confirm you can see my screen?
Yes, we can.
Yes, we can.
Thank you. So, ladies and gentlemen, I will, in the next 5 to 10 minutes, just give you an update of the situation in Africa as regard COVID-19 and what Africa CDC is doing in that regard. So, on the continent so far, worldwide, we have just over 4.1 million cases, confirmed cases, with 280,000 deaths, and a case fatality rate of 7% in 215 countries and territories. On the African continent, we have just under 70,000 cases in cumulative, with total number of deaths 2,400, and over 23,000 people have recovered from COVID-19. The cumulative case fatality rate for Africa is 3.45%. And all these cases have occurred in 53 countries out of 55. Lesotho and Western Sahara are the 2 countries in Africa that have not reported any case. So looking at this epic curve, you can see that the epic curve is still on the upward swing, and we are having a propagated outbreak on the continent, and we may still have some way to go before we can begin to say the outbreak is on the downward trend. So a closer look at the epi situation in the past 1 week, from 4th to 10th of May, you can see that most of the new cases are coming from the countries that are in dark brown, and that will include Algeria, Egypt, Nigeria, Cameroon, South Africa, and all the other countries that you can see in dark brown. When you consider new cases, the western region of Africa, which we call West Africa, accounted for most of the new cases in the past 1 week. So just to give us, as because this is the IPC, we want to just look the countries with the highest proportion of health workers infected as with the denominator being the total confirmed case. If you look at Liberia and Sao Tome and Principe, those two countries, over 15% of their confirmed cases are from health workers. And we have another two, Niger and Namibia, with over 10% of their 10% of their confirmed cases coming from health workers. So we in Africa CDC are thinking of an intervention to address this in some of these countries, and we shall be contacting them soonest. So for surveillance, what have we been doing in terms of surveillance in Africa CDC? The surveillance working group have been conducting webinars, just like we are doing in IPC. They've been doing that in English and French. They've published guidance documents to help member states as they respond to the COVID-19. One of the last one they published, the revised physical distancing guide. You know, because COVID-19 is continuous, so we get new and new evidence, and therefore some of the guidance that we produced needed to be updated. So they also hold weekly meetings. In the laboratory, and I believe this is one of the strongest points Africa CDC made and has been doing on the continent. So far, a total of 1.2 million tests have been done on the continent with about 5.5% positive rate. We've distributed, Africa CDC has distributed over 500,000 test kits from the Jack Ma Foundation, and from our own side, over 139,000 from our own side. Equipment and reagent for Illumina testing for genome sequencing has also we've helped 10 member states with that, and we will soon be getting a sequencing of some of the viral particles as we move ahead. Africa CDC, like you know, one day presented this 2 weeks ago, strategizing for increased testing among member states, which we call the Partnership for Accelerated COVID Testing. So for case management, they've also been doing weekly community of practice webinars in which they discuss current treatments and approaches to COVID-19. Right now, over 1,100 clinicians have benefited from that. So when we go to risk communication, they've been tracking rumors, and as you will know, a lot of rumors are going on about what is happening about this COVID-19 on the African continent. So the questions to assess the potential consequences of those rumors, and then they proffer solution on what to do. So for the supply chain management, just to take you back in memory lane, Africa CDC facilitated the donation, the Jack Ma donation, the first round, which had all of this that you can see on your screen. The second round Jack Ma donation was also facilitated by Africa CDC, which provided member states with the items in the middle column. And then next week, starting from 12th of May, we will be facilitating the third Jack Ma donation. And in that, we have over 4.6 million medical masks and extract about 500,000 extraction kits, and tests will also be part of what will be, including about 300 ventilators. So for the IPC, we've trained a total of 2,000 participants in our training, which is quite impressive. Most of the participants have been from Nigeria, South Africa, DRC, and Guinea. For the English one is Nigeria and South Africa. For the French is DRC and Guinea. Then we are also helping with guidance for PPEs, environmental cleaning, and repurposing of facilities with the clearance team. Of course, we are also helping to identify local producers of PPE, and our research subgroup is also working very hard on research on the rise in healthcare workers' infection across the continent, and priority list has been created based on some of the research questions that have been circulated. As usual, our message to all participants: please wash your hands regularly, observe respiratory etiquette, social distancing, And we know that wearing a face mask correctly can help prevent the spread of COVID-19 to others. Thank you very much, and over to the team.
Molly, over to you.
Can I just start before Molly starts? I just want to welcome Molly. She's an environmental engineer from Africa, from WHO WASH, and she will be presenting for ICANN on this topic of environmental cleaning in healthcare facilities. Thank you. Molly?
Great, thank you so much, Anna, and good morning, good afternoon, everyone. I'm really happy to be here to be participating in this webinar with you all. So thank you for having me. So as Anna said, my name is Molly Patrick, and I'm working at the US Centers for Disease Control and Prevention. So today I'm going to be talking about environmental cleaning in healthcare facilities. Just before I get started, a couple of brief disclaimers. First is that the content of this presentation on COVID-19 references the currently available guidance from WHO and other relevant documents. But as always, this content could be revised as new evidence becomes available. The second disclaimer is that this presentation is generally technical guidance, so it's important to consider that there may be needed changes in order to adapt to your local context or setting. So this is what I'm going to be covering over about the next 30 minutes. So first, I will just very briefly review the potential role of the contaminated environment in pathogen transmission. And then I will spend most of the time talking about the best practices for environmental cleaning in healthcare. And where possible, I will highlight the specific aspects that pertain to COVID-19. So these are the key messages that I want to get across to you all in this presentation. So I'm going to read them to you now so you can keep them in your minds as I go through. The first is that environmental cleaning is important to mitigate the spread of COVID-19 via the contact transmission route. But as we know, the primary transmission route is droplet. The virus SARS-CoV-2 can survive on some environmental surfaces for days, but the environmental survival is actually low compared to many other important pathogens. The third point, environmental cleaning using our existing best practice methods and strategies is effective against SARS-CoV-2. So we do not need to use any novel systems or technologies, which is good news. And the fourth point, which is related, is that SARS-CoV-2 is susceptible to standard environmental cleaning and disinfection methods. All right, so I just wanted to start with a definition just to make sure that we all have the same understanding of environmental cleaning in healthcare and what it includes. So it always includes cleaning, and it sometimes includes disinfection when it is needed based on risk level of environmental surfaces and non-critical patient care equipment. So environmental surfaces include fixed items in the patient care environment and the healthcare environment. And these include items such as tables and chairs, floors and walls, and items that we touch with our hands, such as bed rails and light switches. Non-critical patient care equipment is equipment that only comes into contact with intact skin. So we are not talking about invasive medical devices when we're talking about environmental cleaning. And some examples of this type of equipment include things like IV poles, stethoscopes, incubators, and wheelchairs. If you look at the pictures on the right, so in the top on the right, you can see that the emphasis, so the red points to surfaces that are frequently touched by healthcare workers or by patients or other caretakers. And this is always the emphasis of environmental cleaning. So we always focus on these surfaces, which we call high-touch surfaces. So to be able to explain the potential role that the environment can play in pathogen transmission, we can use the chain of infection. So this is a diagram that I'm sure many of you are very familiar with already. So this explains to us how it is that infections are spread. The 2 points that are very important to raise when it comes to this are first that for an infection to spread, all of these links must be connected, and that if we can break any one link, that can stop disease transmission. So when we are looking at this chain and thinking about the environment and environmental surfaces can sometimes act as the reservoir for infectious agents or pathogens. So there are different modes of transmission. As we know, there is airborne, droplet, and contact. But when we are talking about environmental surfaces that are contaminated, the mode of transmission is by contact. So that is when someone actually comes into contact with those surfaces and then passes on pathogens to a susceptible person, and then they can develop an infection. So it is important to note that you cannot get an infection just from touching a contaminated surface. There actually needs to be that portal of entry. So those pathogens need to enter the body and multiply and damage the tissues to cause an infection. So for COVID-19 virus, we know that there are 2 primary modes of transmission. And for environmental surfaces, it is the contact route that we are referring to. So in the case of this virus, that can occur basically when respiratory droplets land on the surfaces that are in the immediate environment of an infected person. And on those surfaces, the virus could remain viable for some period of time. So how would we break this particular chain of infection? This diagram basically just shows the same as the chain, but just for the situation where we have contaminated environmental surfaces. So if we look at it from left to right, we can see that surfaces can become contaminated, and there are 2 potential routes that they can take to affect a susceptible patient over on the right. The first is direct, if that susceptible patient contacts those surfaces, and the second is mediated by the hands of healthcare workers or caretakers. So we can see where environmental cleaning can cut or break this chain, and that is depicted with the spray bottle. So environmental cleaning can break the chain at the source so that neither susceptible patients nor healthcare workers will actually contact any contamination on surfaces. We can also see that hand hygiene can break this chain. So even if surfaces are contaminated, if hand hygiene is effectively performed, this can also break the chain. So I wanted to just say a couple words about environmental survival. So how long can pathogens survive on surfaces? And the answer is that it really depends on the pathogen. Of course, it is important to note that this is in the absence of cleaning. So we are just talking about the potential survival if cleaning is not performed. Most of the information that we have is from laboratory studies, and the survival in the real world would vary based on a number of factors, including the temperature and the actual surface type. But the table on the right shows you some of the potential survival times for pathogens that we know cause infections in healthcare. And you can see there's a very wide range, in some cases up to potentially months if cleaning is not performed. There have been laboratory studies that have been performed very recently on SARS-CoV-2 specifically, looking at how long could it survive. And you can see that by contrast, it is only a number of days. So maybe in the range of 2 to 7 days, depending on the surface type. And a surface such as wood, for example, might only have survival of a couple days, whereas a non-porous surface, something like plastic or stainless steel, it could be a little bit longer. So that is good news for us. All right, so now I want to transition into talking about the best practices for environmental cleaning. And I wanted to highlight some key documents on this subject. The links for all of these documents are included in the references at the end of this presentation, so you can download them if you don't already have them. The first document on the left, many of you may already be aware of it. This is the Essential Environmental Health Standards in Healthcare, published by WHO more than 1 decade ago. It still contains very good foundational information on environmental cleaning that is particularly well suited for outpatient settings and small clinics. The document in the middle is a new implementation manual that WHO published last year, and it is for the prevention of key multi-drug resistant organisms. There is a whole chapter on environmental cleaning that is most applicable in hospital settings. And the document on the right forms the basis of the majority of this presentation. So this is the best practices for environmental cleaning in all healthcare facilities. It was jointly published by CDC and ICANN last year. All right, so we know that environmental cleaning is important to prevent the spread of infections, and as such, it is one of the standard precautions for IPC, which means that it should be practiced in all facilities at all times, certainly not just during an outbreak or a pandemic situation. Like many other IPC interventions, we say that environmental cleaning requires a multimodal approach, which basically just means that it requires multiple strategies or multiple methods to be able to be implemented effectively. So what are these strategies? The main 5 strategies or elements are listed here, number 1 through 5, and I will be briefly going over these 5 now. I do not have so much time, so if you want to read much more about them, you can go to the Best Practices Manual for more information. A couple of other points, these elements are needed for all types of facilities. So no matter if you are working in a small clinic or a large hospital, there is something from these elements that you should consider when you're implementing your environmental cleaning activities. They're also relevant no matter if cleaning is provided by an external company or if cleaning is managed by hospital staff. So it's still important for the hospital to consider all of these elements and then make sure that they are represented in the contract or the service level agreement. So I'm going to start with the first element here. So that is on organizational structures. And there are 3 main aspects to consider here for best practices. The first is that we need to have strong administrative or leadership support for environmental cleaning at our facilities. This includes designating someone, a facility staff person, to act as the manager or the focal person for environmental cleaning activities. This does not need to be a full-time position depending on the size of the facility, but certainly at a hospital level, you could expect that this would be a full-time position to manage the cleaning activities. It's very important that there is a cleaning facility or a cleaning policy developed and that the leadership actually validates that policy and understands it. Relatedly, it's important that there is a budget to support cleaning activities at the facility level. The second point is on the need for communication and integration of the cleaning program. So the cleaning activities really need to be integrated under IPC, but they also implicate other stakeholders in the facility. Ward level leadership or in-charge staff need to understand cleaning activities. We also need procurement staff or facilities management to understand what it is that is their role to ensure that cleaning can happen according to best practices. And the last point is on the management and supervisory structures. So it is very important, it would be ideal if the cleaning program was structured in a way so that there was an organizational chart or a staffing chart that actually showed all of the people who had responsibilities for cleaning. And on this chart, it is very important that cleaning staff have on-site supervisors, people who can be there to provide supportive supervision, who they can go to if something comes up during the workday. So these are very, very important personnel to consider. And now moving on to staffing and training. This is related. So for cleaning to happen according to best practices, we think it's very important to emphasize that cleaning staff should be formal and full-time positions that are recognized as key IPC personnel in the facility. They should have job descriptions, performance standards, and there should be attention. We understand this is difficult, but there should be effort made to ensure that there's adequate numbers of cleaning staff so that cleaning can proceed according to the policy and the best practices. It is very important that anyone who has cleaning responsibilities, whether that's a nursing staff or a dedicated cleaning staff, has formal training. So this has to include, at a minimum, an introduction to IPC, as well as lots of practice and review, and aspects related to the safety of those workers. Additional cleaning best practices for training are listed in the box to the right, which you can see. So we say that the training should be participatory, it should be very practical and have demonstration and lots of hands-on aspects. It should be conducted at the appropriate literacy level in the right style. And it should ideally be conducted before staff are starting to work on their own and repeated annually. There is a very good training package that has been developed called Teach Clean, and that has been developed by the London School of Hygiene and Tropical Medicine. And that is a very good foundational training program for general cleaning staff. And you can download that for free at the website here. This is also included at the end of the presentation. So moving on to policies and procedures. As I mentioned, it's very important that there is a cleaning policy at the facility. And this would include all of the responsibilities, the staff that have responsibilities for cleaning, the cleaning schedules, the training and monitoring requirements, as well as approved cleaning products and supplies for the facility. Cleaning schedules, there's an example shown on the right. So basically they are tables that would summarize exactly what are the cleaning requirements for every patient care area in your facility. So you can see on the column, they should include the specific patient care area, the type of clean in that area, the frequency, the staff who is responsible, and that would be determined at the facility level, the products and technique, and any additional guidance that is needed. So following from the cleaning schedules, it's also very important that we have SOPs developed for every patient care area. And these would include the step-by-step process for performing cleaning and all of the detailed instructions for cleaning staff, such as the products that are required, the PPE that is required for them. And we should also have SOPs and other job aids for tasks such as preparing, cleaning, or disinfectant products. So I wanted to show the cleaning schedules that are currently being recommended for COVID-19. So I actually forgot to mention, but there will be a standalone environmental cleaning guidance document that WHO is publishing on their website with their other COVID-19 IPC resources. And that should be available in the next 1 week to download. So this table here will be included in that guidance document. So keep looking out on the WHO website for that. So you can see some of the patient care areas described, the recommended minimum frequency, as well as potentially the person responsible, although that would be determined at your facility. The product supplies are listed here. So the cleaning and disinfectant products, and I will talk about the disinfectant products that are currently being recommended a little bit later on in the presentation. But a couple other things to note. We are recommending that freshly made solutions and supplies should be used, and these should be discarded after or reprocessed after each cleaning session in a COVID-19 ward. If possible, it is recommended to dedicate supplies to those isolation areas so that they are not used in other parts of the facility. The recommended personal protective equipment for cleaning staff is also listed here. And then on the additional guidance, these are just some high-level points as far as the areas of emphasis and also the order in which some of these key steps should proceed. So for example, for inpatient rooms on the second line, you can see that the focus is on these high-touch surfaces, starting with shared or common surfaces and then moving towards each patient bed. So you would have to develop an SOP for each of these areas that is based on your facility and the layout in your facility, but these provide some basic guidance on the techniques. So I just wanted to go over these best practice techniques very briefly. So whenever you are making an SOP, it's important to keep these principles in mind. So we always want to make sure that cleaning is proceeding from cleaner areas to dirtier areas. And some practical examples of what that actually means are included here in the bullets. So for example, we would always say to clean high-touch surfaces that are outside of the patient zone before we clean the high-touch surfaces inside the patient zone. And that is illustrated with that picture on the right. And that's because the contamination level will increase as you get closer to the patient. We always say to clean patient beds or patient areas before patient toilets. And on the last point, for example, we say that you should clean general patient areas before isolation areas. And that's because we would expect more contamination in those isolation areas. So for example, for COVID-19, if it is not possible to have dedicated supplies or staff to those areas, you would want to make sure that your cleaning is proceeding on a daily basis with general areas or unaffected areas prior to cleaning those COVID-19 areas. We always say as well that cleaning should proceed from higher areas to lower areas, and that's basically just because contamination can drip and fall down towards the ground as we clean. So some practical examples, we would say to clean, if you're cleaning a full patient bed, you would always be cleaning the rails before the patient, before the bed legs. And we would always say to clean environmental surfaces before floors. Finally, we should always make our SOPs so that cleaning can proceed in a systematic manner. So there's no right or wrong way to do this, but it should be in a manner so that we don't miss key areas. So it could be left to right or clockwise, and you can see the picture on the right that illustrates this. All right, so now I want to move on to the fourth best practice element, which is the supporting infrastructure and supplies that we need. So there are 4 aspects here, and this is really where WASH comes in. So we need to make sure that there is dedicated space at the facility for environmental cleaning. So an environmental cleaning services area would be where we would keep all of our cleaning supplies and where we would prepare cleaning solutions. We want to make sure that there are effective water and wastewater services, which is a challenge. But that's why we need to have strong WASH programs at our facilities to make sure that we have enough water to make our cleaning solutions and that we can safely dispose of them. The third point is on the need to have approved environmental cleaning products and supplies, and then relatedly have the procurement systems in place to manage those. So I want to spend a little bit of time just talking about products, because we have a lot of questions that are coming up about disinfectants for COVID-19. So this is just a definition very quickly of cleaning and cleaning products. So cleaning is the physical removal of foreign material. It's achieved generally with water, cleaning products, and using mechanical action or scrubbing. So it is always the first step in environmental cleaning, and generally under routine operations, cleaning is the only step that is required. There's different cleaning products. Generally, we would recommend a neutral detergent that's soluble in warm or cold water. For disinfection, now disinfection is actually a chemical process when it comes to environmental cleaning that uses chemicals on our environmental surfaces or inanimate objects. It always occurs after cleaning. There are different levels of disinfection based on the nature of the use of the object that is disinfected. For environmental cleaning, we are focused on low-level and mid-level, sometimes, disinfection. We do not use high-level disinfectants for environmental cleaning. And importantly, all of the organic material and soil should be removed before we apply disinfectants. So this is important to remember. I wanted to show what is called the disinfectant hierarchy. So what this does is it lists the main classes of microorganisms according to their resistance to disinfectants. So you can see how high-level disinfection, mid-level, and low-level correspond to those different types of microorganisms. One thing to note here, so we start at the top, the most resistant to disinfectants, and those are bacterial spores. And as we work down, they become less resistant. And we can see at the bottom, the most susceptible to disinfectants, that's where we have our enveloped viruses. So we see that SARS-CoV-2 is actually very susceptible to disinfectants. Whereas we can see, for example, small non-enveloped viruses are more resistant. So that's something that's important to keep in mind. So how does this actually relate to disinfectants that we all know and that we use in healthcare settings? So there are many different types of disinfectants, low-level and mid-level disinfectants that are used. If you look at the table, there's a lot of information here, but you can see the first 2 lines are on low-level disinfectants. So these are our most common that we would use in healthcare setting, and those might include quaternary ammonium compounds or chlorine-releasing agents such as calcium or sodium hypochlorite at 500 parts per million. alcohol at 60 to 80%, chlorine releasing agents at 1,000 parts per million, and a product such as improved hydrogen peroxide all act at that mid-level of disinfection. So those are stronger disinfectants, just to show you here. So those mid-level disinfectants can actually inactivate from mycobacteria level all the way down. So they are very strong. But low-level disinfectants, you see, cover all of the vegetative bacteria, which are mostly what we are seeing in healthcare, along with enveloped viruses. And then there are some cases where a higher level product may be needed, but this is not for routine environmental cleaning. This is only for specific instances. So for COVID-19, these recommendations will be included in the WHO guidance document that I recommended. But in making the determination of a disinfectant that we should be using in healthcare facilities in the context of COVID-19, we have to take into account not only SARS-CoV-2, but some of the other clinically important pathogens that we know are in healthcare facilities. And this is because we know that our hospitalized patients are at risk for other infections as well. So there are 3 disinfectants that have been identified that would be effective both against SARS-CoV-2 and also the vast majority of other clinically relevant pathogens in healthcare. So that is on the second bullet there. So for all 3 of these, ethanol at greater than 70%, hydrogen peroxide at 0.5%, or hypochlorite at 0.1% or 1,000 parts per million, these are all mid-level disinfectants, so they will be more than effective for SARS-CoV-2 and many other pathogens. There's a recommended contact time of at least 1 minute for these. And there are, in the box, there are just a couple cases where a higher level of chlorine might be needed, but it's very important to note this because under the vast majority of cases, we do not need to use 5,000 parts per million chlorine. It's very strong. So it is only if there are these very environmentally hardy pathogens that are known in the healthcare facilities, such as C. difficile or C. auris, Candida auris. And if we have very large blood or body fluid spills, then we will be using this higher level of chlorine. But otherwise, 1,000 parts per million is the new recommendation that's coming from WHO. And this is very conservative. This is still more than enough, and it will be very effective against SARS-CoV and many other pathogens. There are other disinfectants that you can use, of course, if they have demonstrated action against other human coronaviruses. So for example, some of you may know that the EPA has published a very long list that is being updated that has all sorts of other disinfectants that they know will be effective because they are label claim against other human coronaviruses or harder to kill organisms, such as those non-enveloped viruses. So we know in that case that they will be effective against SARS-CoV-2 if they're able to inactivate non-enveloped viruses, because those are much more resistant to disinfection. So I want to talk a little bit just briefly about preparing cleaning and disinfectant solutions and our best practices. So we want to do this in our dedicated service area, making sure that we are following manufacturer recommendations for the PPE that's needed to safely prepare those. CDC has recently published this graphic on how to make 1,000 parts per million chlorine solution from different compositions. So from bleach or from HTH, high test hypochlorite, or bleach or chlorine powder. So it's very important to keep these points in mind, that we need to make sure that PPE is used when preparing chlorine-based solutions, that chlorine is stored in a covered plastic container, and that we're making a new solution every day unless we can test to make sure that the concentration is still good. It's also very important that we are not mixing chlorine solutions with any other cleaning products. For our supplies and equipment, we would recommend just a couple points here, if possible, to use dedicated supplies for your COVID-19 wards. And if possible, you could also, if you have different colors of cleaning cloths, we would also recommend that those would be, you could color code the use of those. So you could use one color of cloth in your COVID-19 ward, so you know that those are the type that should be used there, for example. The PPE required for cleaning really varies based on that particular patient care area. So this table includes all of the different PPE scenarios that cleaning staff would need to consider. This is available in the best practices, so you can always refer to this after. So for COVID-19, the PPE that is required is for droplet precautions. There is some reprocessing guidance here that we wanted to include, so you can always look in this in more detail after. So this is how we would recommend to reprocess your reusable environmental cleaning equipment and the PPE that's used for environmental cleaning. And then just a couple words on the last point. So this is a very important aspect to make sure that we are routinely monitoring environmental cleaning and that we're providing feedback to staff. Our best practices would say that you should try to use objective methods for assessing cleaning practice rather than something that is subjective, and that it's good to use multiple methods if possible. The most important thing is to monitor cleaning practice. So you can see on the table in the lower right, there are different methods that could be used, and there is much more information in the best practices to help you determine what are these methods and how could you use them in your facility. But we want to emphasize that it's really important to provide direct feedback to cleaning staff so that they can improve their cleaning practice. This is part of the supervisor's role or an IPC staff's role to do this. So just in summary, these are the aspects that I covered, and these are really about the general best practices. So we know that we need to use multiple strategies, and we need to have strong leadership and organizational support to be able to implement strong cleaning programs. Our cleaning staff, anyone who does cleaning, nurses or other staff, should always be trained and given supportive supervision through monitoring and feedback. We need to make sure that we have cleaning schedules and protocols developed for every patient care area based on risk level. And there are instructions in the best practices to help you determine what is the risk level for every ward or area in your facility. We always want to make sure we use a standardized process for conducting cleaning using our best practice techniques, and that we should take care to select and manage our products at the facility level. So again, these are our key messages here for cleaning for COVID-19. And as I mentioned, these are the references of the documents that I have used in this presentation. So please do download them and familiarize yourself with them, as well as checking out the WHO IPC technical guidance website for this specific environmental cleaning guidance document that should help a lot for COVID-19. So thank you very much.
Thank you very much, Molly. We will have Professor Shaheen Mehta now presenting. Prof, you will share your own screen. Thank you.
Thank you very much. I'm just trying to, I think this is me, yes. Thank you very much, Anna, and thank you very much to the Africa CDC. Welcome, everybody. It's been a while since we've all chatted. I wanted to, just let me start at the beginning here. My talk is going, sorry, come on. Oh, yes. My talk is going to complement the excellent presentation by Molly Patrick. The reason I wanted to do this was because we seem to be sort of engulfed with fear and very concerned about how we're going to get rid of the coronavirus. And now, as we know and we've understood, that it's a very, very sensitive virus indeed, very delicate, very sensitive. But there seems to be a residue of Ebola in most people's minds. And so there has been a complete overkill and a complete over-movement towards trying to get rid of this virus. And we also seem to, for some reason, believe that there are areas around where this can actually lurk behind us and when we're not looking, infect us. So what I would like to do is to just go through the whole concept or just try and summarize some of the work that has been done by several of colleagues, including myself, looking at what the spraying issue is all about. So first of all, I think I just wanted to remind you, and you've heard this from Molly, looking at the various spread and transmission, but just to remind you that in the environment, well, the one that Molly was talking about, we are actually looking at the area here, which is the contact, that is the patient zone and the healthcare zone, and we really are not terribly bothered about the airborne transmission part of it, unless there is an airborne generating procedure, an aerosol generating procedure. However, as generally, we are just concentrating on the left-hand side. And it's quite important that we understand this, because if we can get rid of the surface contamination, then I think we're fine. The other thing which I need to mention here quite clearly is that there is no evidence, absolutely no evidence of re-aerosolization. Indeed, it's very difficult to show aerosolization, and the only one that's actually probably shown that has been tuberculosis out of dust and so on. But basically, there is no re-aerosolization. So once the virus particles land on a surface, they more or less stay there, and they will remain there until they are removed. The other thing which is quite important to remember is that these spread very clearly through sneezing, as Molly mentioned, coughing and talking, and also from contact, in other words, via hands. There isn't any evidence, published or otherwise, where you would find the virus which will be spreading through contaminated feet, wagon wheels, horse manure, or anything else which is happening outside. And I think this is very important, because the whole concept of spraying the environment and humans comes from the fact that they think that there is something going on. So let's just see where this arose. I mean, where did this whole concept of spraying the environment start? Well, it started in the 80s, the 1980s, where there was large volume spraying and fogging and misting going on. And the target there was not a human being, but a mosquito. And in Africa and other parts of the world, there was a huge amount of spraying, as you can see over here, of the mosquitoes in the place where they were, to get rid of yellow fever, dengue, Zika virus, and malaria. Now, this approach was twofold. This was to get rid of the larvae on the surface with a very thin layer of oil on top, or this would be to actually try and spray the bushes and the grassy areas where one would expect to find the adult mosquito during the day. And that was what that came from. However, what then transpired quite clearly was that this was considered to be environmentally very damaging. It was most of the product used was DDT. While the mosquito eradication was quite effective, it was causing a huge problem with humans, with human health, and as well as the environment. And therefore, it has been banned in many a country. So basically, the concept of spraying a chemical in the environment was not to kill humans, which is, or to affect humans, but to actually get rid of mosquitoes. So what does this then tell you as a person who does infection prevention? What does this picture actually tell you? He's a man walking around with a cloth mask, not even a proper mask, and he's got something on the back that's called Rescue. And this is applying a misted disinfectant, probably chlorine, because that's the most common thing around, and you can see that there's a lot of rusting around, over an area which is on the street or the pavement or the back door, the point of which nobody has actually understood. It is not evident to us, because we now know that if we leave the house, we'll be wearing a face cover, a cloth mask, and we will be doing our hands, and we'll be socially distancing. So if we've touched anything, the chances are that we will very, very quickly decontaminate our hands, and therefore the transmission is practically negligent. This is a talk from Beijing, which I just wanted to bring to your attention, because a lot of the videos that we saw on television and on the social media showed people in hazmat suits spraying everywhere. Well, this is quite important that we understand that most of those were either coming from China, or they came from Taiwan or South Korea. But the Chinese have very clearly said is that excessive disinfection should be avoided in China as an ongoing fight for coronavirus. And there is the effect of disinfection has to be prioritized, but you have to be very careful how you use it. And basically what they said was that, please don't do this. A series of guidelines on disinfectant techniques have been published, and they have enhanced the popularization of knowledge. There's a circular going around on disinfection, and there's a working party ruling as well. And basically what they said, that the number of conditions where disinfection should be limited such as there should be no large-scale disinfection outdoors and no outdoor disinfection in rain, snow, and other conditions. And it also warned against spraying disinfection on humans, putting disinfectors into into ponds, reservoirs, artificial lakes, and so on. So it was very clear that even though the pictures were telling us one story, the structures and the administration in Beijing very clearly said, please do not do this. However, this didn't really stop. And this is a picture from April in Peshawar, showing this poor chap who's supposed to go to the healthcare facility now has to walk through a tunnel of chlorine. And here is a document that actually came out at the time, which said, talking about the spraying of chlorine. This was signed off on the 13th of April. And this document, this particular picture was sent to me, and I had to respond to this, to the Pakistani government, which I did. And following that, they then, on the 13th of April, sent out this document, which said basically that, you know, regarding the above matter, hypochlorite spray tunnels for disinfection of humans, an advisory is issued by the WHO, which states that spraying disinfectants like chlorine or alcohol over the body does not kill the virus. Rather, it is harmful for clothes and mucous membranes, so in other words, should not be done. Hypochlorite solutions are recommended for disinfection of surfaces and instruments, as we heard from Molly. However, disinfectant tunnels have created a false sense of security, and people might be diverted from hand washing to disinfectants. And in some of the places, they walk around like this because they think if they walk forward like this, they will disinfect their hands as they go through a tunnel. So as the above circumstance, it was recommended that the tunnels should not be installed or used, and in fact, 3 of them that were up were removed. But the fact of the matter is, by this time, damage had been done. And this is a picture very reminiscent of those of you that were involved in the Ebola outbreak, where people would rather die of a heart disease or non-Ebola infection than go to the healthcare facility. People would be outside and they would be sprayed by these people here for no apparent reason. There's a lady over here who's walking past and then gets attacked by this man with a spray. Now, this is quite important that we understand that spraying using chlorine is dangerous and it's illegal. It is not allowed in any of the high-income countries, and nobody in their right mind would be expected to be sprayed because in the Second World War, chlorine gas was used, as most of you know, in gas chambers to kill 1 million or more people. Humans should never obviously be sprayed by chlorine, and I will show you some of the evidence. So the evidence for this is very clear, that the toxic effect of chlorine is that if you actually inhale or swallow chlorine, okay, there is water inside the body, and I hope all of you can actually see this, and this water changes the chlorine into hydrochloric acid or into hydrous acid. Both of these acids are obviously extremely poisonous, as we know. Nobody knowingly would actually swallow or take this on board. So this system then leads to a change in the acid levels of the blood, causing an acidosis, and that causes low blood pressure and people die. And it's very interesting that this, in fact, was published mainly due to accidental exposure by NIOSH, which is the American system, as well as the European system. But what was also very interesting is that some of the people that were put in the back of a van during Ebola was sprayed, the back of the inside of the van was sprayed, it was closed, and they went for 3 hours in 45 to 50 degree temperatures to another part where they were then pronounced dead upon arrival and said that they died of Ebola. And thoughts are that possibly it wasn't Ebola, but it might have been chlorine poisoning. And I'd like you to think about that very carefully. This was a study that we did in Sierra Leone, looking at the deliberate exposure, and I'd like to just give this information to you as briefly as possible. We compared 500 healthcare workers with 550 Ebola patient survivors and 500 non-Ebola cases. And we looked at the way they were sprayed. So we had to remove 7 from the one group and 23 from the other who had never ever been sprayed. However, just to look at where the healthcare workers were sprayed, 61, which is 12%, was sprayed in the back of an ambulance. The red zone, 93% was sprayed in the red zone. That was including somewhere where I work, but I never ever allowed myself to be sprayed. I would like to just state that up front. While they were exposed while they were spraying others. They were exposed while they were in the room when others were being sprayed. Okay, now that was about 24%. And then they would be inside a house where the person with Ebola was diagnosed, or in a suspect's house. But of great interest was that the EVD group, that they were pre-transfer, they were sprayed. Then 99% of them were sprayed in the back of an ambulance. Okay, as we mentioned. All of them had to be sprayed before they left the ETU. Okay, and then 22% were in the red zone. Of these guys who were sprayed who were not Ebola, they got nothing to do with Ebola. 92% of them, if you can see my pointer, 92% of them were sprayed while they were in their own house under quarantine, sitting there minding their own business, and they got sprayed. And of course, the back of the ambulance, 8% got sprayed there. So now what I want to show you is some of the other evidence that comes up, that if somebody had an eye problem before and they had a single spray, 7% of them would actually have an eye problem, and those that had multiple sprays was 12. But what's of interest and statistically significant is that they now, after single spraying, 34% have developed eye problems, and 59%, more than half of them, after double exposure, developed a problem with their eyes. Coughing increased from 38 to 60%. Coughing with sputum went to 29%. Difficulty in breathing, chest tightness and burning of the throat, and skin irritation in 52. And many of my colleagues who were from Europe working at the time in Sierra Leone had come to us, and they were showing us where they had skin allergies and irritation. So just by single exposure, there's quite high. But by doubling, by multiple or twice exposure, as we see here on the left-hand side, you will notice that it's very, very serious indeed. So if you put up a tunnel and people are walking in and out of that, the chances are very, very high. Now, does it matter whether you're wearing PPE and you get sprayed? Does it protect you? Well, the answer is here. If you're wearing eye protection, and many of them always wore eye protection, and the hygienists wore eye protection as well, and they wore skin protection, as you can see here, and most of them did significantly. It made no difference, and I just want to show you that. It made no difference because the eye infections in the healthcare workers compared with the Ebola survivors was a bit less. But look at the chest. Look at the infections of the chest. They were double that of Ebola survivors, despite the fact that they were wearing eye protection and skin protection and PPE and everything else. So by wearing protection, it doesn't protect you, which then again begs the question, if you're putting people through these disinfectant tunnels, there's a main problem of them being sprayed. Their clothes are soaked, it goes into the skin, it goes into the lungs, and it goes into the eyes. And there's been major damage there. A paper that came from the American Journal of Infectious Control, it just clearly shows where they looked at 163 staff who were interviewed, and they took some approximately 50 air samples were taken. And what they saw was that if these people were involved in making up or dealing with or using disinfectant, which is the darker line here, which I hope you can see, versus where no disinfectant product was used, very clearly there has been a high incidence of watery eyes, of nasal problems, of asthma-like conditions, okay? And this might remind you to go home and have a look at this, particularly those of you who've got children who've got asthma and skin disease. Think about how much chlorine you use in your environment, in your home, never mind outside. The chlorine that you use in your home constantly trying to keep the environment clean. What does that have? What effect does that have on your child? And this is a major issue that is now being looked at in the United Kingdom as well as in other parts of the world, where they say that the children that have grown up in this very sterile environment have a much higher incidence of asthma, skin conditions, and eczema. So these people also had shortness of breath, and there was a huge problem with asthma and allergies. So in fact, the use of these disinfectants wasn't all that amazing. I just want to take you to a slightly different slide before I finish. And this is the impact of chlorine on antimicrobial resistance. For those of you that have been involved in antimicrobial resistance, I just want you to note that some of the work that was done by a group in 2016 They looked at 22 genera that were genes that were organisms that were isolated from chlorinated drinking water and looked at their susceptibility to chlorine and antibiotics. And what they found was very, very interesting. The chlorine-resistant bacteria had a higher MIC. In other words, they were more resistant to tetracycline, sulfonamide, and amoxicillin, which in fact are carried on the same chem plasmid. In the presence of free chlorine, antibiotic-sensitive bacteria survival was less than the antibiotic resistance, as we would understand, because that's why we chlorinate water. But there was a correlation found between tolerance to chlorine and the MICs, or the minimum inhibitory concentrations, against these organisms through the transmissible genes. But it was not affecting ciprofloxacin, which is a different mechanism of resistance, looking at the efflux pumps and the porins. So the antibiotic-resistant bacteria survived longer than antibiotic-sensitive bacteria when they were exposed to free chlorine. So throwing a lot of chlorine around in the environment, using it on the surfaces, using it everywhere is fine for you. But in fact, in your homes and in the streets and in the healthcare facilities, there must be a very defined way of using disinfectants. And because it has not only an impact on human health, but it also has an impact on antimicrobial resistance and One Health programs. So the disinfectant and the environment, the problem with chlorine is it's not biodegradable, so it'll accumulate in water effluent and waterways, and it kills normal flora, and obviously will allow the increase of multi-drug resistant pathogens, which are now being widely detected in water systems. It has an impact on soil and nitrogenous products. It has an impact on fish and wildlife, which you can look up yourself, and there's a huge detrimental impact on the environment. So if you're going to apply chlorine, which sometimes you do, and the question is that if SARS-CoV-2 is such a sensitive organism, such a sensitive virus, why are we applying disinfectant at all? Is it because our cleaning methods are not good enough to cope with it? Or because we're very bad at cleaning? Or that because we're just so scared of the virus or what it does to us that we have to, for our own purposes, keep on applying a lot of chemicals to make us feel better rather than kill the virus. So even though I totally agree that it's a very low level disinfectant required, I think we have to be quite clear in our minds of what disinfectant we use. And I personally favor, as most of you know, I personally favor alcohol over chlorine because it evaporates and leaves a dry surface, whereas chlorine leaves a residue. However, if you are going to be applying chlorine as a disinfectant in 1 in 1,000 parts per million, not 5,000 parts per million, but 1 in 1,000 parts per million, it should be wiped. It's sprayed on a cloth, wiped over the surface, and not sprayed. So the take-home messages are, please listen to what Molly said. She said some really important information for you, which I hope I have not repeated, but just emphasized on. First thing is that before you do anything else, first you clean, and then you can disinfect. The second thing is, if you're applying chlorine to a surface, then you are going to apply it after cleaning, and you wipe and you don't spray. Okay. Then the third thing is that if you are applying the correct concentration for the correct length of time, this is very, very important indeed. Just because you want to kill it because you're scared, and you make the concentration stronger, doesn't help the virus and doesn't help you. Most disinfectants will only work at a particular time, at a particular given time. Okay. So they will work in their own concentration in their own given systems, and they must have the contact time. All right. So you can wipe off the surface after the contact time is over if it to reduce the corrosiveness of chlorine, especially on metals. You obviously will not be spraying the environment with chlorine, I hope, anymore. You certainly will not be spraying humans with chlorine any longer. And most importantly, that you must remember that just because SARS-CoV exists, its RNA may be detected using PCR, it doesn't mean that the virus is viable or infectious. And this has been proven in many a paper saying that they have tried to grow it, but it hasn't been able to be cultured, except in 1 and 2 exception situations that Public Health England has been talking about. The thing which I want to say is that if you look at the papers by Kampf and by De Boerden and all these other people, it shows that the virus can survive for 7 to 10 days. And if you look at and if you think about what Molly said, where cleaning frequency has now increased from 1 day to 2 days, to twice a day. And in fact, for us in South Africa, in the ICUs for COVID, we are using it 3 times a day. And in the toilet in areas which we think are high contamination areas, we are cleaning 3 times a day. The chances are that the virus doesn't survive. It cannot survive, particularly if you make sure that your validation systems are in place. So on that note, I shall leave you, and I thank you very much for your attention. I think I took about 3 minutes more than I should have, but I'm happy to answer any questions. Thank you very much.
Thank you very much, Professor Mehta. And we will hand over now to Africa CDC to handle the questions and answers for the panel. Thank you. Over.
Thank you very much, and thank you very much, Shireen and Molly, for a wonderful presentation. We will now welcome questions. Please, participants, kindly move to the question and answer chat box. Our panelists from Africa CDC, WHO EMRO, WHO Headquarters Geneva, WHO AFRO, US CDC, ICANN, and Public Health England would be available to answer your questions. So the first question is being directed to us as Africa CDC. It says, with the increasing cases of healthcare workers' infections, does Africa CDC recommend routine testing for surveillance or surveillance for frontline workers? So Mohammed, over to you to answer that question.
Okay, thank you very much, Wande. So we in Africa CDC depend on when it comes to testing on the guidance of the member state on their testing policy. That's what I want to say. The testing policy of member states on issues like this. So we will advise that the person who asked the question can check what the policy of testing for health workers is among the member states, and it also depends on at what level of the epidemic or transmission the member states are. But generally, if at health workers that are working in the treatment centers, and when we encourage, even here in Nigeria where I'm working, we encourage them to have a kind of routine testing, just because they're handling patients, and so that we can quickly pick when they have infection. Over one day. You can say something from the headquarters too.
Okay, thank you very much, Mohammed. Just to add on to what Mohammed has said, so as Africa CDC, what we're trying to do is to collect this data of healthcare workers' infections to give some sort of guidance based on the available evidence to member states, which member states will consider in terms of what their testing strategy is. So we're working very hard closely with our countries to ensure that all testing strategies are evidence-based and context-specific. Moving on very quickly, there's another question for Africa CDC that says that healthcare workers are contacting COVID-19, which may be hospital or outside within the communities or during doffing. And most countries are not looking at that. So this question is just trying to find out from us, is it the lack of training on IPC? What are the steps taken by Africa Union? And are healthcare workers being exhausted in all ministries of health? So just to say that, as with every pandemic, there's going to be a toll on the workforce. And we as Africa CDC, we're supporting countries. My colleague mentioned the number of countries that we have current footprints. We have trained 37 countries on IPC. We've done physical trainings. Before the lockdowns, we trained about 37 countries, English and French. We train their national IPC focal persons, and we're working with them. We're working with them now to cascade that training, that previous training that we have done. As also mentioned, we're doing some sort of supplies in terms of PPE for our countries, and we're also looking at deploying IPC experts according to the needs across various countries. So the next question, WHO colleagues, if you're happy to take this, there's a question about guidance for home care management and what sort of cleaning is recommended for home care management. So over to you, Alice and EMRO colleagues.
Yeah, for home care management, we have to be caring for the room for isolation of suspected patient. We have to clean using the same concentration of hypochlorite, which is, we are saying, 1,000 parts per million. Taking care during the cleaning that we should wear a mask, gloves, taking care of cleaning of the toilets, and everything that may be contact with the patient. Of course, the cleaning supplies after finishing should be cleaned and disinfected and left dry till repeat the cleaning procedure. We have to stress for the aeration and the good aeration for the room in which the patient is kept. This is the general measures, and there is a special guidance for home care management present on the WHO website, affordable and can be downloaded. Over to you.
Thank you very much for that. This question, Molly and Elizabeth, if you're happy to take this, colleagues from US CDC. So it's, the question is, there are two questions, and I think participants are wondering that what sort of guidance or recommendations are we making for people working at airports and seaports in terms of what cleaning measures should be done for passenger transport. So I think I have two questions a bit about airports and seaports. So if colleagues from US CDC are happy to take that in terms of what our general recommendations should be for cleaning. Over to you.
Hi, it's Elizabeth, and I'm going to defer to Molly Patrick, who, as you can see from her presentation, is truly an expert in cleaning.
Thanks, Elizabeth. I was going to defer to you because I worked on guidance for airports and ports. So I think, I mean, as far as the principles of environmental cleaning and disinfection, the areas of emphasis, the products that should be used, really, it would be, as I have shared, so, emphasizing the use of, wiping, not spraying, focusing on high-touch surfaces, always cleaning before a disinfectant is used. These would be the same principles no matter what the application is. I saw a question about buses, for example, so really focusing on our best practice techniques, no matter if it's a bus, a plane, or any other setting, are the main things that we would want to communicate. I do think that both WHO and CDC does have guidance that is published on our websites with more specifics by sector. So whether that's an airline or an airport setting or a port. So yeah, maybe I'll just leave it there, but there certainly is more detailed guidance, but the principles would be consistent with the information shared today. Thank you.
Absolutely. And to piggyback onto what Molly said, there are a lot of guidances on CDC and WHO website. I will say that in previous guidance from WHO, it was recommended to use the 0.5% chlorine in healthcare settings. And some of those recommendations of that higher level of chlorine may have also been used in some of the other guidances in non-healthcare settings. Now that WHO has switched to using the 0.1% setting in healthcare settings, I think that that's a more appropriate standard, especially in non-healthcare settings where you're not so much worried about non-healthcare settings where you're not really worried about C. diff or Candida auris. So I suggest going to the WHO documents that have very, very good principles. But one thing you might keep in mind is switch.
Thank you very much for that. Very quickly, Shaheen and ICANN colleagues, I think this question is directed to you. So it says, does it really mean that governments all over are actually wasting scarce resources spraying around? And another colleague from, sorry, looks like you lost me for a second. Very quickly, Shaheen, this question is for you. It says that our governments all around wasting scarce resources on spraying. And a colleague from Zimbabwe says that they just commissioned this disinfection tunnels and they're having challenges in convincing people that it's not very beneficial. So over to you, Shaheen and ICANN colleagues.
Thank you. Okay, so I think this is true. Most of the people who make these decisions are completely uninformed. They have no idea what's going on. And of course, somebody tells them that this is very good for you. They decide that, yes, it must be very good for you. There is no evidence behind it. In fact, it's quite the opposite. The CDC, hopefully this WHO document should be out by Thursday, which clearly states that please do not do this. Previous document, this is the same document, by the way, that Molly is referring to as well, which has got more information in it. The healthcare facilities, and unfortunately, people who make decisions in government are not the experts. And this is one of the reasons why a ministerial advisory committee is very useful, so that they can give you the evidence so that you can make sure that you make the right decisions. So if you don't provide PPE to healthcare workers, but you spray everybody with chlorine, it rather begs the question of where your money is being applied. And so I, for one, would not ever accept that. They also, don't forget, a lot of people who are selling and making good, so that they want to make the most of this particular situation, and they really work on the fears of the people and the governments, and they provide them with all sorts of gadgets that they think are going to help them, and it is up to us not to buy them. And that is simply it. That we would not be buying, we would. Having said that, there are two areas now in South Africa, in the Joburg. One is on the Gautrain that they put up a tunnel, and the other one is on a big taxi rank. And we are asking of the government, why are you doing this? I mean, what is it? What proof do you have that this is going to work? And can we please have the chemicals that you're spraying humans with? Because under the Human Rights Act, you're not allowed to spray humans with detrimental chemical toxins, basically, So, yeah, I mean, I think it's very clear to me that there's no indication whatsoever, because there is no transmission by that route. When you spray people, what are you saying? You're not spraying it up their noses, you're not spraying it on their hands. So what exactly are you doing by spraying their clothes, which I think, and their bodies, and giving them this really serious illness? So I hope that's answered your question.
Thank you so much, Shaheen, for that. Just to let participants know that we have put the post webinar survey polls up. Kindly please answer some of the questions. It'll give us some sort of clarity on how well this webinar has benefited you and how the impact on what your knowledge is. Next question is directed again to Africa CDC. It says that, what is Africa CDC doing about improving the training across countries? And do we see the need to sort of this environmental cleaning as a sort of training or a package for countries? So I'll go first, then I'll let my colleague Mohammed, who is also online on the field, to just add on to that. So yes, we do see the need to continuously train healthcare workers across the country. What we're doing now, because you know that many countries have implemented some sort of airspace closure or border closure, so it's been difficult to travel. What we are doing now is deploying in-country IPC experts to support with the trainings going on in countries. We're also working with ICANN colleagues in across several countries to do some sort of step-down training on IPC for healthcare workers. In addition to that, we are running webinars like this, and we plan to provide remote comprehensive support on IPC. If you're aware about the Telegram chat, you can directly pose your questions to experts that are currently online, and we're happy to give you our experts' feedback on how to handle the situation in your countries. And regarding environmental cleaning, Molly mentioned something about Teach Clean. We are going to be putting that on our website, a link, so that people can just go there and download the materials available for environmental cleaning. So over to you, Mohammed, if you have anything to add on to this.
Thank you very much, Wande. So,
can I just please, I'm sorry to interrupt you, I didn't mean to. I really want, I'm getting so many questions about this, about the disinfection tunnels, and they've been commissioned by government and so on. And I wanted to actually ask whether the Africa CDC feels it has the power, with all the evidence behind it, to actually make a statement to say that this is unacceptable for humans, and that it should never, ever be allowed. Would you guys be in that position to ever do that?
Absolutely. We have a guidance subcommittee of the TWG that looks at that. And one day you can put that on some of the things we should be doing to look at. Basically, today's presentation was very clear on use of chlorine on humans and stuff like that for disinfection. So we will consider it. We'll put it on.
I think you need to more than consider it.
Yeah, we are going to do it. We'll put it on our to-do list.
There's lives at stake here. This is
absolutely. Absolutely.
You know, if any one of the people that got sprayed take you to the Human Rights Commission, including you, I don't know whether any of you have ever been sprayed. Have you ever been sprayed? So I'm strongly recommending that this be something that comes out of this particular meeting.
Absolutely.
And it's really useful that we all sign it. CDC, the United States, the CDC, ICANN signs it, WHO signs it, we all sign it and say, no way would you allow this to happen. We have to do this because we're killing people for no reason at all.
Yeah,
we will definitely table it on the top agenda in our next TWG meeting.
Thank you, Dr. Mohammed.
Thank you. And to also respond to the previous question, it's like Wande rightly said, it's difficult moving people around. Just before the first case in sub-Saharan Africa in Nigeria, we brought quite a number of African countries to Abuja, where we did the training for IPC. Yeah, then there was no issues of border closure, international travel, and other issues that have really caused total lockdown in most of our countries now. Again, during an active outbreak like this, in which some countries are already having community transmission, and if you remember in the previous presentation, they talk about asymptomatic spread. We will not. We tried to shy away as much as possible from bringing people into to do face-to-face, so as because of fear of spread of the virus. But what we do, like Wande have said, is we continue to do this webinar. We support step-down in-country training using, very fortunate for us, ICANN, Affinet, and even some WHO, both WHO, Afro, and EMRO experts in country to continue to train and ensure that this very important competence is impacted on our healthcare workers. Africa CDC is also looking at how to conduct some kind of operational research that can provide evidence as to the best way forward for infection prevention and control. We recently saw a paper that was published in Tanzania that really talked about it's not just enough for you to bring these materials, PPEs, and give to health workers. You must teach them, train them how to use it, and encourage a behavioral change on the fact that they need to make this part and parcel of their everyday activity, not just what they do once and that's all. So we will continue to do that, and we hope ICANN and our partners will continue to support this process. Over. Thank you.
Thank you so much, Mohammed, and thank you so much to the panelists. Most of the questions that were posed were answered live, so we always encourage colleagues to put their questions onto the Q&A chat box where panelists can actually type the answers directly to you. So thank you very much for joining. Over to you, Anna, to do the closure.
Thank you very much, Hiwande. Can I just ask if Idua can just share the closing QR scan for the participants? I know that some of you had some problems with this. This is just a testing, and we will continue using this in future. So if you do have any problems with that, just please send us some details on the errors, and we will try and see how we can fix that for you. If Idua can just share the last screen with the start and the end QR code, please. Idua? Just leave that on for a little while. Okay. And then I just want to thank everybody for attending, and just join us next week again. For the French people on the call, there will be a French version of this on Friday. So every week we have an English one on Wednesdays, and on Fridays we have the French version of the same presentations. Thank you very much, and enjoy the rest of your day.
Thank you all.
Thank you.
Thank you, Anna. Thank you, Donde. Thank you, everybody. Bye.
Thank
Thanks,
you.
Thank you,
everyone.
everyone.
Bye.
Thank
Thank
you.
you. Yeah.